medcram.com.
Welcome to another MedCram lecture. We're going to talk about MRSA infections.
Here's what we're going to cover in the next 4 videos. A brief review of the differences between MSSA, MRSA, healthcare-acquired MRSA, and community-acquired MRSA. We'll talk about the risk factors for MRSA, virulence factors that typically make community-acquired MRSA worse than hospital-acquired pneumonia, and we'll illustrate chest X-ray and CT findings for MRSA pneumonia. We'll talk about the clinical decision and diagnosis of MRSA. We'll compare Vancomycin and Linezolid for primary treatment options. We'll also talk about Telavancin, pros and cons, and how it compares with Vancomycin, and why a variety of agents may not be ready for primary consideration for MRSA pneumonia. We'll also talk about specific treatment considerations for community-acquired MRSA, and finally, we'll tie it all together and review.
Before we talk about MRSA, let's talk a little bit more general about infections from Staphylococcus aureus. Staph in Latin means grape-like, and then coccus means like a grouping. So this would be like a grape-like grouping. This is what it looked like under the microscope. And then Aureus, if you'll notice, the periodic table AU is the symbol for gold. And they noticed that these colonies were golden looking. And so that's where we came up with Staphylococcus aureus. It's basically a very opportunistic bacteria. It likes to invade, likes to go in, and it can cause some very bad infections, specifically in the skin, but also in the lungs. And there's 2 major types or branches of Staphylococcus aureus, 2 major types of infections. And it has to do with the antibiotics that we use for a Staphylococcus aureus. In both situations, of course, it's a Staphylococcus aureus, so they'll have a SA. But the antibiotic specifically that we use as a litmus test to find out whether or not this Staph aureus is one type or another is something called methicillin. Otherwise can be used as oxacillin, but methicillin typically is the one that we use. So the ones that are sensitive to methicillin are called methicillin-sensitive Staphylococcus aureus, and the ones that are resistant are called methicillin-resistant Staphylococcus aureus. So we have MSSA specifically and MRSA. Obviously, MRSA is not sensitive to methicillin, and as a result of that, there's a whole class of antibiotics which can't be used against it. It's resistant to it, it does nothing for it, and the patient gets worse. And this can be seen in a number of different situations. So methicillin sensitive, basically you can use a wide variety of different antibiotics. MRSA is also likewise divided into 2 groups, which you may not be aware of. There are actually 2 types of MRSA. One of them is known as the healthcare acquired MRSA, and the other one is known as the community acquired MRSA. And as it turns out, the community acquired MRSA is very, very virulent. We'll talk about that a little bit in just a bit. The hospital-acquired or healthcare-acquired MRSA is the ones that we typically see in the hospital, but there's been more of a blurring, and we'll talk a little bit more about that. So just be aware that there's a healthcare-associated MRSA and there is a community-acquired MRSA. Both of these are resistant to methicillin, of course, and then there's methicillin-sensitive. We're going to talk a little bit about the epidemiology. We'll talk about the clinical features, specifically as it relates to pneumonia. And we'll talk about the treatment and the treatment options that we have today for this. Okay, so we're going to talk about MRSA just in general. MRSA has been described all the way back to the 1960s. And what they noticed is that this strain of Staphylococcus aureus was resistant to methicillin. That's how it got its term MRSA. This incidence since the 1960s has definitely increased without a question. And in fact, to the point now where if you would take a look at all the different types of strains, for instance, in an intensive care unit, about 60% of the Staphylococcus aureus is MRSA, and this is growing. And that accounts for about 90,000 infections per year. So that's pretty significant. Now, how does this work? There's something called penicillin-binding proteins. So penicillin-binding protein, specifically the penicillin-binding protein 2A, is coded by the gene, you may see this, the MEC-A gene. And this MEC-A gene, which can be shared around to different types of Staph aureus, they can all get this penicillin binding protein, which basically inactivates methicillin. So that methicillin doesn't work. So it all boils down to this penicillin binding protein 2A, coded for by the MEC-A gene. And this is a mobile genetic element, which means it can be transferred to bacteria that don't normally have this ability to be resistant to methicillin. So you can get new generations, it can be transferred. And so this is a real problem, because if we have a lot of this going around, we get more and more antibiotic resistance. So that's MRSA. Let's talk a little bit about the different types of MRSA that we alluded to earlier. Okay, so there's the healthcare-acquired MRSA. Let's talk about that one first. The thing that you've got to know about these two different types is that they were identified based on the risk factors and in the environment in which they were found. And so they're named for their history. And so you can see that the healthcare-acquired MRSA was a particular strain of MRSA that was seen in hospitalizations. And so typically we would see these in people who had been in the hospital for greater than 48 hours or within 12 months of being in the hospital if they came in from the outside. So in other words, these were people that were discharged to a healthcare facility, or they came back into the hospital but had been just recently hospitalized or in a nursing home of some sort. Or they were in the hospital and this happened 2 or 3, 4 or 5 days after they were hospitalized. Now, this has been increasing in prevalence since the 1980s, 1990s. Once it got to around the 2000s, 2010, the prevalence started to even out, maybe even go down a little bit, and we'll talk about why. And I can allude to that. The community-acquired MRSA started to increase in terms of that. If you were, however, to compare MRSA to MSSA, okay, especially this healthcare-acquired MRSA, the healthcare-acquired MRSA had patients that had increased length of stays in the hospital, increased mortality. That's comparing it to the MSSA. And this makes sense, right? Because if you have someone with MSSA, you're going to, generally speaking, select the right antibiotic up front, even if you're giving them like Rocephin or ampicillin or something like that. There's a good chance, especially if you're using one of these second-generation penicillins, like methicillin, etc., that you're going to hit the MSSA. With MRSA, unless you're using Vanco in these situations or other antibiotics that we'll talk about later, you're not going to get it, and therefore mortality is going to go up, especially if it's a very severe infection. Okay, let's talk about CA MRSA, and I think we're going to get into this a little bit later. But the two big areas, and this is the biggest one that this was seen, was in the skin and the soft tissue. This was pretty big about in the early 2000s, mid-2000s. What was happening is that they were starting to see in high schools and colleges that gym equipment, football equipment, were getting colonized with this type of CA MRSA. And these students were coming down with horrible MRSA infections that were a lot more difficult to treat than the type of infections that they were seeing in the hospital. This was also seen in intravenous drug users. Also in the 1980s, we're also getting these types of infections. And why was it that the community acquired, in other words, the strain of MRSA that was seen in the community, why was it acting so different? Well, it's because of this thing called the Panton-Valentine factor. And this is a virulence factor. I don't want to get too much into it, but they was also causing leukocidin toxins. And there's different antibiotics that could make the toxins worse, and there's other antibiotics that could make it better. There's still some argumentation about which type of antibiotic is better for this. The bottom line that you need to know is that the type of strain of MRSA that was seen in the community and is actually increasing and in fact overtaking this strain that was seen in the hospital is very, very virulent and very aggressive, difficult to treat, and has an increased mortality. The other thing that you can see, especially if this causes a pneumonia, is you get a severe necrotizing pneumonia, that sometimes the only way you can make them better is to surgically remove that portion of the lung. So the thing is that because these strains were first identified, this one here in the community and this one here in the hospital, we kind of looked at this differently. You know, if the MRSA is coming from the hospital, it's generally going to be a hospital-acquired MRSA. And of course, if it's coming from the community, we got to be concerned that it's a much more aggressive and virulent community-acquired MRSA. The fact of the matter is now is we're starting to see a blurring of these two types. So in other words, we could actually see this strain occurring in the hospital setting, and we could see this strain occurring in the community setting. And so it's very important to look at the types of strains and see how the behavior of this bacteria is. Let's talk about risk factors. What are the risk factors that you got to look for in patients specifically to be worried about MRSA in general? So let's talk about these risk factors, and they kind of go for both. Of course, the most obvious is going to be, previous antibiotic use, because we know that this causes resistance. Specifically, cephalosporins, which is kind of scary because we use that all the time in community-acquired pneumonia. But the one that is associated with the most is fluoroquinolones, like Levaquin. But let's just say in general, it's fluoroquinolones. And that one is big time associated, and we use that all the time in community-acquired pneumonia. The other one is HIV, and this specifically goes for the community-acquired MRSA, believe it or not. Things that wouldn't surprise you: hemodialysis catheters. These are catheters that are left in place. They get MRSA all the time. Long-term acute care facilities or subacute care facilities. Obviously, this is going to be big time if there's colonization or there's contact. In other words, very poor hand washing. And that goes along with the environment. Again, risk factors: antibiotics, HIV, hemodialysis caths. So catheters, these Quinton catheters, long-term acute care facilities, colonization, contact, environment. So I think you know and understand a little bit about what MRSA is, where it comes from. It's basically Staph aureus. It's basically a resistant strain. You know what the protein is. It's a penicillin-binding protein. It comes from the MEK-A gene. There are different virulence factors which makes community-acquired MRSA much worse than the run-of-the-mill hospital-acquired pneumonia. In fact, let's look at a survival curve, and I'll distinguish that. That'll make it very clear between these two. Okay, so let's draw a graph here. Let's look at survival. So on this, we're looking at survival, and here we're looking at days post-admission. And let's say in the blue, we're going to look at those that are the Pathophysiology leukocidin toxin negative. So that would be like basically your hospital-acquired MRSA. And then we can also look at the yellow, which is the Valentin leukocidin toxin positive community-acquired MRSA. So in terms of that, the survival was pretty poor, basically going down here and leveling out at about 30%. Whereas the survival for the hospital-acquired one, and again, this is kind of blurring, was a little bit more like this in terms of the survival, as you can see here. In this situation, you can see clearly that the survival was much worse in the community-acquired one because of that toxin. So next, let's talk a little bit of some of the manifestations of MRSA pneumonia and staph pneumonia particularly, and what we could see.